Welcome to the Suicide Prevention Show here on 1360 WLBK, a show that tries to shed a little light on the darkness of suicide. With us, as always, Chuck Seabrass. How you doing, Chuck?
I'm doing great today, and as always, I'm happy to be here and expand on this subject.
Very good. Citizen Mike, great to see you again, my friend.
Fabulous to be here. Thanks for including me on the journey.
And we are without Tamara Sutton today, but visiting with us again this week is Dr. Paul Quinnett from the QPR Institute. And we're going to talk some more about the QPR method, too. But, you know, Paul, we've been doing this show just over 3 years now. And I know when we started the show, we talked to people about talking about suicide on a weekly basis. And frankly, they were a little shocked and taken aback, and they realized that nobody talked about suicide for years, and now it's coming to the forefront. And Paul, we thought we'd start today's show by going back and looking at suicide through history, and you're quite an authority on that subject, and I wonder if we can kind of go back in the years and look at how suicide has been viewed through the years.
Well, that's, I think, a good question in terms of giving your audience a historical perspective on sort of where we came from and where we are. And very briefly, the first known suicide note was written by an Egyptian in 4000 B.C., and we know that suicide was not uncommon in the ancient world. It wasn't uncommon in pre-European America. It's been in most cultures that we've studied over the centuries, as far as the historic record can tell us. We know that in the Roman army, when they had a completed suicide, the punishment for the victim was to crucify him, Christian style, which was the worst thing that you could do to a Roman soldier. And this was done to discourage other suicides from occurring. But the real change came in St. Augustine's time. If anybody's a scholar of the Bible, you'll find that there are either 8 or 9 completed suicides in the Bible, but none are condemned. Nothing bad happens to these people. Even Judas Iscariot is not promised forever in hell. That only comes after St. Augustine's period, when there were so many Christian martyrs. They were afraid they might not have a church because martyrdom led you to heaven. And so the commandment, thou shalt not kill, was altered a bit to include yourself. Thou shalt not kill yourself as well as anyone else, and that made suicide a sin. Had not been a sin up to that time. Well, when it became a sin, as the church and state were one in those years, and particularly during the Middle Ages, it also became a crime, punishable by, in some cases, a death. In Britain, a failed suicide attempt led to it was a capital offense, and the state would hang you if you failed to kill yourself.
Wow.
The other financial aspect to this, which I think is interesting, is that the coroner, the Crown's man, determined the cause of death. And if the cause of death was determined to be suicide, then it was a crime, and the property of the deceased was reverted to the Crown. And so by suicide death, the rich became richer, and the families were punished. The bodies were desecrated, placed face down in graves at crossroads where they wouldn't be able to sleep. In Germany, they put the bodies in barrels and floated them down the Danube River. The bodies were punished, the families were punished, and to some extent that's the legacy we've been dealing with and fighting now for the last few years. In fact, Sigmund Freud wouldn't treat suicidal patients because they might damage his reputation.
And so there was a stigma on the family as well as the individual.
Absolutely.
Really?
We have been punishing families out of this historical perspective, and it's way past time that was ended. And I've worked with so many families and have been a part of the new movement here in America, which began, and it's very interesting because Senator Reid was one of our champions in the early going here back in 1998, and Senator Reid lost his father to suicide, Senator Reid from Nevada. And today I saw legislation introduced for particularly funding suicide prevention efforts among our elderly, which is where the rates are the highest.
Wow.
And so but America's changed. We have legislation, we have funding. There's a lot of work to do in terms of awareness and enlightenment, but we're about where we were with the cancer word. Remember, cancer couldn't be talked about in America until Happy Rockefeller told her personal story to Life magazine, most widely read magazine in America, that started a whole social movement. And that's exactly what's happening right now in America. Suicide is no longer you guys are helping tremendously, by the way, bringing it out of darkness, because that's exactly what needs to happen.
Thank you.
I'm glad we're talking about this. Here are two pieces I hadn't known before in terms of that within Christianity, martyrdom was considered a method of going to heaven. Now, we've heard that more recently in terms of Islam and in terms of the suicide bombers and those sorts of things. However, I have never heard it associated with Christianity. And then the other thing is, in terms of taking the dollars, the property, and reverting that to the crown, my first thought about that was, well, that could get families an incentive to be able to intervene on behalf of the person who's feeling this way. And then what it occurred to me is that a lot of times if you don't know how to do that you're not very effective, but it certainly would give people an incentive to hide suicide, which is one of the things that we're hearing today, where people talk in terms of when they were children, if somebody in the family completed suicide, you're not supposed to talk about it. You keep it as a family secret instead of doing something about it.
Yeah, Janet Hurtado from the National Suicide Foundation told her as a young woman, her cousin committed suicide, and she was told by the family to not speak of that ever at any time.
Yeah. Absolutely.
Well, it's interesting. In my family here, I was had written a couple of books on it, and and I was in my mid-50s, I suppose, and my father, who was alive then, said, "Well, I guess you know enough about this that we can tell you about your uncle." It was an uncle once removed, but he was a member of our family, and he'd gone through a late life depression and got out in the deserts of California and shot himself. Wow. And they had never told me, and I was a fully grown man and almost a grandfather. So we have stories. We had a story come out of North Dakota, a woman in her 80s. We had a pastor up there who teaches QPR as part of what he does in his church. And after the service, she waited for him until everyone had left. And then she said, I've been waiting 55 years to ask somebody this question. She says, my son killed himself when he was 18, and I want to know whether he's been burning in hell since.
Wow. That's pretty amazing.
That really is.
Now, you were
and he was the perfect person, a psychologist and a clergyman, to alleviate that guilt and that terrible pain that she'd been in all those years. It's just amazing.
Absolutely, and that kind of highlights the value of getting professionals throughout our society trained to use the QPR method in terms of listening and being able to keep people engaged and talk about this very difficult topic. Now, you had been talking to us about the history of suicide completion, and bring us up to more current times. You were saying there used to be a time that we couldn't talk about cancer, and we began to talk about that. Tell us a little bit more in terms of what's happening. Tell us about the research of suicide today.
Well, there's different levels of research going on. I think some of the exciting work is being done in brain behavior studies in terms of the mental illnesses that underwrite these suicidal thoughts and feelings and completions. A lot of the public probably doesn't know that of the people who actually die by suicide, 90 to 95% of them are suffering from what's called an Axis I psychiatric illness, which means major depressive disorder, bipolar disorder, schizophrenia, alcohol or substance abuse disorder, and often in combination of one or more of those. And that what we really are seeing here is a fatal outcome to these treatable illnesses. And if these were any other kind of illnesses that weren't stigmatized, we would not tolerate this 1 minute. I mean, here in my state, in Washington, we lose 2 young people a week, 104 a year, to these illnesses. And if those were, cardiac illnesses or flu or, any other kind of cause of premature death, we wouldn't tolerate this. We would pour research money and prevention, family education into this like crazy. But we seem to tolerate this, and I think it's partly because the word is stigmatized, the behavior's been stigmatized all down through history, and we still haven't rounded the corner.
We're talking
parity and access and the things that are before Congress right now.
Talking with Dr. Paul Quinnett from the QPR Institute. And Paul, I was wondering now, when we talked to a police chief here not too long ago, and he was talking about it, oftentimes may be an apparent suicide is not reported as a suicide. And I was wondering, as you study a suicide through the years, is that a problem where cases that may have been a suicide were not reported as such?
Well, let's put it this way. There's all kinds of reasons to underreport suicide. In a famous study done in San Diego County involving the in-depth study of single-car fatalities. These are high-speed crashes that occur with no other passenger or driver involved. In other words, they didn't hit another car. They just hit a post or went off a bridge or something like that. When they went and did what's called a psychological autopsy, looked at their medical records, interviewed their families and friends, and did a very in-depth study of that, like you would a homicide, they're called psychological autopsies, they found that half of those high-speed crashes were suicides. Half of them.
Wow.
And so when you apply that number to the medical examiner's challenge, in many cases they can't tell whether it was a suicide or not, and their inclination is to rule an accidental weapon discharge that happened to strike the patient in the head, and I've seen this again and again and again. So we know that of the 32,000 reported suicides in the last reporting period, that's an undercount. By how much, we really don't know. But because of this lack of accurate information, there's been new federal funding to fund what's called the National Violent Death Surveillance System. And that is proving very helpful in a closer examination of these deaths. I wish that we would do an in-depth examination of all suicides so that we had a better understanding of what happened that might have been a preventable event, because we think most of these are preventable deaths.
And as you said, Paul, many reasons. We know insurance, for one, reporting it through the insurance company and with the results that may have. But I guess a lot of it goes back to the family itself, doesn't it? The stigma, again, we're talking about, and the family not wanting to admit that it was a suicide.
Well, that's certainly true, and you can't blame families at this phase of our education. The Evangelical Lutheran Church has published a wonderful white paper on this. We're seeing more leadership from clergy. In fact, we just finished a 2-year project teaching QPR to the U.S. Army Chaplain Corps, chaplains and chaplain assistants, who are taking it Army-wide and reframing it, of course, as an Army issue. And we have all these returning veterans who are at elevated risk, and a lot of us are real concerned about how we're going to educate their families in how to recognize symptoms and signs and warning signs before something bad happens.
Considering those things, Paul, what do you recommend to the average listener who's listening into this program, or the average person? What can we do about this whole situation?
Well, I mean, there are a number of awareness programs out there. I would give the website www.SPRC. That's the federally funded Suicide Prevention Resource Center.org. www.sprc.org. There's a lot of good information there, even specific information about what workers can do in the workplace and college students and so forth. They have a lot of excellent information. There's quite a bit of information on the web in general. The suicidology.org is another area where there's some good information. The reason we do what we do is to try to give people a 1-hour to 2-hour training program that gives them sufficient knowledge and self-confidence that they can actually do this. It's kind of like in CPR. You actually have to practice on the dummy to know if you can do it. So we have what are called role-play situations where we have one person exhibit some warning signs, and then the intervener, the family or friend, asks the question and actually does the intervention. And we think that practice piece is important. And it takes, QPR training session is about 90 minutes to 2 hours. If you go to our website, you can get training there. The people are listed by state, all the certified instructors by state, and then you can just get a hold of the Institute for someone near you that can come to your facility, organization, or church and do a training. Or you can take the training online, or you can become a trainer and learn to teach it.
But you want to be sure, right, Paul, that the person teaching you is certifiably trained in the QPR method.
Yeah, and they will have gone through a training program and been actively, and they're certified for 3 years. And if their name isn't listed on our website, then they're not current. You can call the office and check just to be sure, but that's part of our quality control matters. So, and as I said, we have it. It's taught in all kinds of settings by all kinds of people, and so it's a big tent concept. That's the way we've thought about it.
Fabulous. Now, we're going to have to wrap up here shortly. What would you say are some of the key messages you want to get out to our audience?
Well, first I'd say that the person most likely to prevent your suicide is somebody you already know. And likewise, that means that you may be the only person in a position to prevent a suicide, because you may be the only person that's close enough friend or colleague or acquaintance of that person to receive the warning sign. It's kind of like a gift, It's like I'm telling you that I may be thinking about killing myself, and what is your response going to be? And so that's a key message. The other one that we have is we realize the public health nature of the problem, and so we feel we have to train hundreds to save one, thousands to save hundreds, and millions to save thousands. And it's just like that CPR concept we talked about in another show. We have to train as many adults as we possibly can. We think this should be mandatory training for firemen, for law enforcement people, for any first responder, 911 call takers, crisis workers. Everybody should be at least comfortable enough that when they see a warning sign, they can clarify it that it's a real warning sign and needs attention, and that person needs to get some help. So it's something everybody should get involved with, and I know that's a big task and it's a tough subject, but I don't know how we're going to get there without everybody being willing to listen and to take a small part in it.
Words of wisdom from Dr. Paul Quinnett from the QPR Institute. We're going to take a break and come back and talk some more about the QPR method. You're listening to the Suicide Prevention Show here on 1360 WLBK.
Mental illness does not discriminate.
It affects people of every race, age, gender, and social class.
It could be a loved one, a friend, or maybe even you. But you are not alone.
The National Alliance on Mental Illness supports individuals and families touched by mental illness.
Call NAMI Illinois at 1-800-346-4572 or visit our website at il.nami.org. We understand, and we are here to help.
The WLBK Suicide Prevention Show recently won the Silver Dome Award as the best public affairs radio program in Illinois.
Some of the extraordinary people we've talked to. First one that comes to mind is Denny Miller, a delightful guest, and really gave us an insight as to what it's like to be a coroner and have to deal with the prospect of somebody committing suicide.
We had the police chief on who spoke about how really difficult that is to investigate suicide and telling the families about what that's like. It's really far-reaching. Friends and family, neighbors are all so much more deeply affected than most of us realize if we haven't been touched by it ourselves.
I was under the old myth that if you talk to somebody about suicide, if you actually use the word suicide, that would prompt that person to commit suicide. And Chuck, we've learned that's not true.
It's very not true. The more you talk about it, the less stigma there is, the more comfortable the person that's having those thoughts. They feel a little more free to talk about it, open up, and hopefully not complete that act.
Join us Sunday morning at 9:30 for the Suicide Prevention Show on the station that cares about its community, 1360 WLBK.
Welcome back to the Suicide Prevention Show here on 1360 WLBK, visiting with Dr. Paul Quinnett from the QPR Institute. And, one of the subjects we covered, Citizen Mike and Chuck, is we've talked about how people say, pick yourself up by your bootstraps, you're fine, come on, shake it off, go get a self-help book from the library and heal thyself. And we understand, Paul, that you wrote a book called When Self-Help Fails, and explain that book, and if you would, explain the concept behind that.
Well, the idea was that years ago, and this book is now, I think, out of print, maybe available on Amazon or something, but this was back in the consumer movement when the onus was put on the consumer of anything that you purchased, that you needed to be informed and research your purchase and research your provider. And
buyer beware, right?
Yeah, buyer beware. And so I wrote it with regard to mental health services. How do you find a good practitioner? Who should you see first, second, third, and so forth? And so the idea was basically to inform the consumer about how to raise up the profession by putting it to the test. And it's sort of like when I took my son. He had Hashimoto's syndrome, which was required a surgery of his thyroid, and he was like 14 years old. And the surgeon was interviewing him, and at the end he said, "Is there any question you would like to ask me?" And my son said, "Yes. What kind of grades did you get in surgery?" And so what the consumer out there who has a suicidal loved one needs to find out is what kind of grades did the practitioner who's going to treat my loved one have in the area of suicide prevention and risk assessment. And unfortunately, the answer is that there isn't a course offered in this. In the vast majority of graduate schools and medical schools, they have almost no attention paid to this major area of public health and premature death and disability.
And Paul, you have every right to ask that question, right?
I believe you do, absolutely. I mean, here's what, it's not me, it's the Surgeon General's report. The National Strategy for Suicide Prevention, Goal 6, says that healthcare professionals must increase their knowledge and skills in this area of practice, and that colleges and universities and medical schools need to improve their curricula so that their graduating professionals are better prepared to work with suicidal patients. To date, not much of that has happened, and so what's happened, of course, is that the consumer is beginning to see suicide prevention. The Surgeon General said it's our most preventable death. So if I take my brother who's suicidal to you as a practitioner, and you don't do a good job with him, and he dies, what am I left to believe? What is my conclusion? That you were inadequate, that you weren't trained, that you didn't know what you were doing. As a result, guess what the number one cause for malpractice now is against all mental health professionals? Number one cause.
Sounds like it's
suicide malpractice.
Oh, okay.
Is that right?
Really?
Yeah.
Wow.
And so now we have, state of Georgia, for example, had 100 and some unexplained deaths in their state hospital system, 7 hospitals. The Atlanta, what's the paper down there?
Constitution.
Yeah, made a huge expose of this. And part of the reason was that patients who were coming into the hospital suicidal were not being properly assessed and managed and took their own lives on their hospital campuses. So this kind of failure to sort of get up to speed in terms of patient safety, what I call patient safety, is made the field a little hot right now. So if you have a loved one that's suicidal, you need to be sure that you've got a good referral from your primary care physician. Who would he take his loved one or her loved one to see? And perhaps a telephone interview with that provider. Do they feel able and competent to work with someone who's considering suicide?
It sounds like we would take the same measures of buying a used car in terms of finding out who the mental health professional is that we want to get referred to. And because we all know that in terms of used cars, they may be good or they may not be good, but you can do these different types of assessments, use your own network to find out who would be a quality person to take them to. Are there some specific questions that consumers might ask in order to be able to make this happen?
Well, I think a couple of them come to mind immediately. One is, have you worked with suicidal people in the past, and have you had training and supervision in how to assess and manage suicide risk? Now, in terms of standards of practice, I can tell you that psychiatry, in almost all cases, has had that training, and they also are capable of writing prescriptions. So if people ask me, who would I take a suicidal loved one to, I'm going to first assume that the illness they're suffering from is significantly dangerous, that medications are probably going to be indicated. So my first stop would always be a board-certified psychiatrist. Psychologists can do this. They can get others to prescribe for them, but their standard of practice, and I'm a psychologist, and their standard of practice isn't quite that high in terms of their obligation and duty, as it were, to conduct a comprehensive suicide risk assessment. They're getting better. There have been new publications just out from the APA doing a much better job in this area. But in social work and nursing and so forth, those professions haven't paid much attention to this.
So as more people ask the question, the people, the professionals will become more aware of the need for this and perhaps begin to take the training.
That's what the plan is, and there are a number of organizations offering advanced training in this now. SPRC, I mentioned them in an earlier show, Suicide Prevention Resource Center. We offer an advanced course for professionals at all levels and primary care as well. We think it's a very important part of the safety net is to have competent consumers working with competent providers. I mean, if your child is diagnosed with cystic fibrosis and you're a parent, what's the first thing you do? You Google that up and you find out the best clinic in the world in terms of survival of this illness, and that's where you move your family. Well, one day people are going to be thinking this way about mental health services. Where are the centers of excellence for treatment?
Now, Paul, I can think in terms of myself doing that, doing the Google thing, do the research, yada, yada, yada. However, in terms of asking a doctor, have you had this kind of training? That's a question I'd have to ask my wife to ask the doctor, because I'm one of those people, quite frankly, that came under that authority thing. So I'm kind of scared to ask the question. I think there might be some other our listeners out there in my kind of boat. What would you have to say to us?
Well, I would say that you would want some assurances from somebody that the person you were going to take your loved one to felt prepared and comfortable to deal with this problem. In the same, I mean, if you think about it, primary care physicians, for years and years and years in America, we said, well, if you're sick and have a problem, go see your doctor. Frankly, most doctors are so busy, they don't have time for this problem. And they're seeing a patient every 6 minutes, pediatrics every 9 minutes. As I jokingly say, the doctor in America who cares if you're suicidal is Dr. Marcus Welby, MD. And the reason he can talk to you is he only sees one patient a week. The rest of and I have lots of physician friends, and we train physicians all the time. Physicians are really being hammered now by the managed care company systems, and they have very little time available for comprehensive conversations with patients about items like this. And what they need is co-located mental health professionals in the next office that when they probe for suicide and they find a patient is positive, is thinking about it, they can say, I want you to see, so-and-so, they're right next door, and they walk them to that appointment. They walk them right over there. You have to give doctors a way to deal with this effectively. We're asking way too much of them to practice psychiatry on top of what they have to do in medicine right now. They have more problems to deal with any given patient than they ever had before and in less time. And so I think America needs to wake up that your family doctor, while he or she may be terrific, really is being challenged to try to give the kind of time that a psychiatric patient needs.
I think that's great advice for folks. The other thing I'm thinking about is something in one of your texts that you wrote about the issue in terms of just asking the question about suicide. And part of the point is the downside of asking the question for someone who's not experiencing it is I might suffer a little bit of embarrassment. But the part of it is if the treatment is needed and I don't ask the question, well, then the costs are really high. And so when I think about it that way, I think I might be able to muster the courage to ask a doctor directly, or like you're saying, then find another way of asking them. It may not be quite as direct, but find out their competency to treat.
And your reoccurring theme is refuse to remain silent, Citizen Mike.
Yes.
So that ties right in with that. Dr. Paul Quinnett from the QPR Institute, thank you so much for visiting with us today.
You bet, and thank you.
And that's the Suicide Prevention Show for today.